I've only got about 20 slides, so we can have as much conversation as you want, and I'll try and keep it to a minimum so we can keep things on track as much as we can for today for you. So recruitment, basically, the important thing to remember is this is the beginning of the relationship between the employer and the employee. Whether it's a physician recruit or a nursing recruit, recruitment isn't, a process that's forgotten later. And then, okay, now that you work here, now we can develop our relationship. The first handshake, the first phone call is where people start to size each other up and say, can I work for this person? Do I like this person? Are they going to do good things for the department, good things for me? So it's very important that your best foot is forward and your realistic foot is forward. You don't want to paint a picture of someone that you're not. This establishes the basis for employer and employee expectations. If you mention to people, hey, listen, we have a democratic department, we do fair scheduling, and you're doing that because, well, that's kind of what I do with my recruitment spiel, but that's not really what happens in your department, that's a problem. Those expectations have been laid there in your recruitment process, and you've got to fulfill those. The critical piece and principal stakeholder is the medical director. Because if you don't hire the right people, your department's going to be really in jeopardy. It's going to be hard to work there, and you're going to have to keep recruiting and finding people to replace the people who didn't fit to begin with. Now, this concept kind of is represented in the business literature as well, called the psychological contract. Anyone here ever pull their contract out of a drawer? After working somewhere for a while, do you ever pull it out and look at the termination clause? Once your doc or nurse or whoever has done that, your relationship is over. If it's that bad that you're looking at how you can get out and you're looking legally how you can get out, it's a bad situation. More important than the written contract is this concept of the psychological contract. That's that unspoken bond between the employer and the employee saying, these are the things that you expect of me and what I will do, and here's what I expect of you and I will do. And it's so much more important than the written contract because on a daily basis, you can damage this agreement, damage this relationship. And if you're not treating each other with respect, you damage the psychological contract. All right, so recruiting, what do we need to do? We've got to assess our departmental needs. How many people do we need to staff our department comfortably? How many shifts per month do the docs want to work? Do the nurses want to work? So how many FTEs do we need? And what mechanisms of recruiting are out there? We'll talk about them. And I think you need to recruit for improvement. Anyone here overstaffed right now? Okay, we'll see you at the next lecture. That's, what time would that be? But, still, I think you should keep recruiting. How many of you are understaffed right now? Nursing-wise, too, understaffed. So we need to keep recruiting. And I would say for you in particular, and when we do get fully staffed, you keep recruiting for a variety of reasons. And one of those reasons is things always change in emergency medicine. Emergency nursing and emergency medicine with docs, things happen medically. People go on maternity leave, people move, spouses or significant others move, and you move with them. Within 6 months, when you're fully staffed, something changes and somebody moves or shifts or reduces their time or goes out on medical leave or whatever, so you keep recruiting. This concept I want to mention to you, I think is very important too, that a lot of people don't talk about. When you keep recruiting and you become overstaffed, it gives you the opportunity to do better things with your department, much better things with your department. Now, would you rather have your docs complaining that, you know what, we need one more person, we're all work on 180 hours a month, or have your docs complaining, listen, I wanted 140 a month, I'm only getting 120. I would love to have the argument, I want more hours. And boy, those night shifts are coming available, so jump on them, you can have them. And when you recruit for improvement, what you're able to do is to take the lowest performers and say, you know what, we don't have room for everybody potentially. So the only people who can really stay are the ones that are performing up to the level of expectation of the hospital and the department and me as the medical director. And I'm going to help you get to where you need to be. But seeing one patient an hour and being grumpy to the nurses and having a patient satisfaction score in the 10th percentile is not going to keep you in this department when we're overstaffed. And you have the ability at that point to staff and recruit for improvement. So if I can get somebody in here who's better than you, then I will do it. And that sounds ugly and it sounds cold, but that's the job of the medical director, so you can make your department better. All right, so if you build it, they will come. First, define your mission and that of your department. It's very, very important. I don't think the physical plant means that much, because what happens is they come to work for you, the person they interviewed with, the nurse manager, the medical director, that's what they're coming for. And I heard this phrase as well in the business literature, and it makes a lot of sense for us too. People do not quit their jobs. They quit their boss. Does that make sense? Anyone here in their lifetime ever left a job before because they didn't like it? Oh, come on, we've all left a job. All right. And was it really when it came down to it had a lot to do with the boss? I think it really did. You quit your boss, you do not quit that job. So it's important for us to be good to our people and make sure we define that mission. Even if it's a horrible physical plant, we know that if you have a mission and a vision, people will follow you with that because they want to be part of something important and something real. Develop a plan to actualize the mission. Sell that vision to those who you will interview. When you interview, let them know. Here are the shortcomings of this department. Here's where I want to take it, and you can be a part of this on the ground floor. And again, never stop recruiting. Never stop recruiting. I believe in the +1 theory. You need 10 FTEs in your department, you need to be carrying 11. Always look for the extra person. And if you have good people that are applying, it's a horrible mistake to say, I wish I had room for you. Great doc or great nurse just moved in the area and said, listen, I'm looking for a job, I'd like to work for you. I wish I could. But I'm trying to protect my low performers, and they can't work anywhere else and they're here, so I might as well just keep them. If somebody comes to you who has great skills, figure it out. Find space for them. Do whatever you need to do. But you've got to hire them because when you really, really need them, they're gone somewhere else and they will not be back. All right, strategies. Advertising and promotion, screening, pre-interview, and the interview and closing the deal. These are the components that I think are important with recruitment. We'll talk about all of them. So the big thing is you want to cast a wide net. You want to get as many candidates in front of you as you possibly can to decide who the right candidates are for you. Word of mouth is important. There are some departments out there, not many, but there are some that are so great to work in. As soon as a position is potentially coming available, you have 10 people knocking on the door saying, hey, whenever that position comes available, I want it. That's great. You don't have to do a whole lot of advertising. Is that your department? No. So you're saying, yes, I want that department, but no, I don't work in that department. I understand. I'm saying that too. I would love that department. I've never worked there. I don't know. Every place I've ever worked, at some point, has had a significant amount of understaffing. But word of mouth is great if you have that. And have your docs, ask your docs or your nurses, hey, do you have any friends or know anybody that's working somewhere else? You like it because you're here, right? Well, you're either going to find out that they don't and you have to recruit for 2 more, or you can say, go talk to your friends, bring them in. Offer a recruiting bonus. Is it cost effective for you to say, if you can bring me in another doc, I'll give you $5,000? Is that a cost effective approach? Absolutely it is. Can you do the same thing with nursing? I remember in Columbus, when I was medical director there several years ago, Columbus, Ohio, there was a nursing hiring war in the city. Now, some of the competing hospitals would send a limo to our hospital to pick up one of our ED nurses to take them across town for their interview. It's like, uh-oh, we don't have a limo. The limos only went one way. I never understood that. They went one way, they never came back. But it was really scary what the extents they went to recruit people. Advertising is important, but you got to shake it up a little bit. Run your ads. Run your ads frequently. Run them in different places and change the ads. Anybody here from Erie, Pennsylvania? Okay, good. I can talk about this without too much trouble. You may have seen these ads, but in the Annals of Emergency Medicine for probably the last 5 years, maybe more, there's been an ad running for a particular hospital there. At first, it looked really great. It's like a quarter-page ad. You look at it, wow, they got a lot of stuff going on in that place. If you wanted to be in Erie, Pennsylvania, which is a whole nother discussion, then, wow, this place could be great. 5 years running, you see the same ad. Now the perspective is, wow, they can't hire anybody at that place. The ad is hurting them now and they're paying good money for it. Quarter-page ad in Annals of Emergency Medicine every month is not a cheap ad. You got to pull it. You got to put it somewhere else. Change the ad. Make things different. Make it special for people. And you can over-advertise yourself into a situation as they have where all you've done is advertise how difficult it is to fill your department. Anybody exhibiting, nursing meetings, physician meetings, state medical society meetings, I'll tell you, our experience is plus or minus on the value of that. You don't reach a whole lot of people, but it may be fun to do it. Something you can think about. All right, screening. Is anyone screening for you? Or as the medical director or nurse manager, are you screening all the people who are interested in your positions? Anybody? Do you have a pre-screener? You got to have a pre-screener. Usually it's a non-physician contact, somebody who you give the parameters to. For instance, if you want to hire only residency trained board certified emergency physicians, you probably don't want to talk to the pathologist who decides they want to come back and get some clinical shifts somewhere because they ran out of money with their retirement. They don't meet the requirements. They shouldn't get through the screening process. How about locum tenens? Anyone use locums in the emergency department? How's your experience? Not good. How's your experience? Likewise, not good. How's your experience back there? I saw another hand. So yours is the best experience in the group. So. Okay, excellent. Well, great. Good for you. All right. 2 thumbs up. But my experience is the same. that, you know, there are a lot of great locum docs out there. There really are. There's some docs that are very good, and I think the way generally to sort that out is if you're doing locums because you have a defined time frame where you can't commit to a job, you've got a spouse that has to move in a year after they finish education or something, or you just want to see what part of the country you want to live in or what kind of job you want to have, it makes perfect sense. I'm trying some things out without having to commit. Great. Well, when you've got somebody who's trying things out for 10 years, you know, when you're a career locums doc, then you do have to ask the question, why do you want to move so much? Why do you not want to commit? Can you commit here? And I think there can be some real issues with that. And I tell you, the locums firms are very good about making sure that everybody looks good on paper and meets your requirements. And one of the first medical directorships I ever had, I had a huge number of locums docs. They all looked great on paper. And many of them, even upon arrival, it was like, I tell you, we had one guy that showed up that worked for the previous group that had the contract at RED. He refused to take off their lab coat. And I refused to let him work. If you don't take the lab coat off, I can't, you know, I started this contract 3 weeks ago. I'm the new medical director. The hospital took over the contract. They don't like this group, and you won't take that lab coat off. And he said, no, this is the lab coat I always wear. I said, then that's the door you're always going to use, and you'll only see it from the other side. So it was amazing some of the things you can run into. There can be some great docs, but you have to be a little bit careful with it. And when you sign a doc for a full-time position from a locums company, they have also become your recruiting firm, and there's somewhere between a $10,000 or a $20,000 fee associated with that doc. If you got to pay it, you got to do it. If it's the right doc, go ahead and do it, but at least get some parameters in there where you don't have to pay immediately, make sure performance is good, that if the doc works out for 6 months, then you'll pay the second half. It's something to protect yourself a little bit. We had a contract a couple years ago that we had a little bit difficult time staffing, so we tried locums again, and we had the same experience. We didn't have great experience. We had one doc, though, that kind of worked out, so we went ahead and hired him full-time. But he wouldn't commit to the area, didn't move in, would fly in just like he did with his previous locums arrangement. And then things didn't work out because they got a call from the local Hampton Inn. The first call was, you know what, we really don't allow rats as pets. He had a pet rat that he kept there, and, you know, once in a while it would get loose and run down the hallway. It was freaking people out. Well, even the Hampton Inn got by with that. They were like, all right, it's one of your docs, we'll live with it. When the rubber hit the road was when he set the freaking hotel room on fire. And I tell you, we still don't know how the hotel room got set on fire, but the Hampton Inn pretty much said, okay, now we're done. Get the rat and the doc and get them out. You know, and you never know. That doc at that point in time had how many charts that were outstanding undictated? Anyone? Throw some numbers out. It's important. It's impressive. 200? Anybody else? 300? Anybody else? I feel like an auctioneer up here. 763 charts. So would you mind finishing your charts before you're done? Does it really help for them to see the patients and we can never bill for the services provided? And then from the risk management standpoint, not having a documented record, horrible. And so the so-so doc, because we're pushed into it with a staffing issue, is it really worth it? The answer, again, when we revisit this, tends to be a lot of times, no, it's not worth it. Pick up the shifts yourself. Maybe you can pay your local docs a whole lot extra to avoid that trouble. And depending on how your screening process works, you want to make sure you talk to the right people. Is this the person you want to interview? This is the person you want to hang out with after the interview. Absolutely. But this is probably not the person you want in your department. Make sure the screening works for you. Okay, the pre-interview, after they've been screened and they get to you, the medical director should have or the nurse manager should have a pre-interview on the phone. Let's establish the fit. Do they really work? Does it sound like they will like the department will like them, and they're going to get along well? Establish the goals, not for employment, but the goals of the interview. Hey, what do you want to talk about? What do you want to see? Tell me what your concerns are with your last job, because I want to show you how this will be better. Structuring the interview, identify interview discussion items, and identify personal interests for the local tour. You've got to get them locally invested. If you think you're going to get somebody to sign on with their family without showing them the community, it's not going to work. And a real estate tour is not enough. Oftentimes, what is the goal of the real estate agent? To sell a house. And if they get the hard sell on a house and they don't get to see the community, they just get to see houses, that does not make a very good impression. All right, the interview. Now you bring them in the interview, and what you're doing is confirming the fit. Okay, on the phone it sounded good in the pre-interview. I liked you and I thought this was going to work out great. Now I'm going to have you sitting in front of me, spend a day with you, and let's see if it works. Identify potential issues. What are the problems that might come up with employment with this person? And don't avoid the tough questions. Don't dance around this, because you don't want to sign the wrong person. Signing the wrong doc or the wrong nurse doesn't help anybody. You have to undo it later, and it's really problematic. It really is. So ask the tough questions. So you've had 3 jobs in the last 3 years. Tell me why, and tell me why this job would be different. I know they probably weren't great jobs and this would be different, but I just want to make sure that you're going to be committed to staying here. If they can't handle the tough question that's deserved, then that should tell you right away, what the relationship would be like. Do you have to dance around every topic in the interview? If you do, expect to handle that employee the same way, dancing around every topic. You can't work any Saturdays. Why? Oh, I don't want to upset you. No, the interview process at this point, you need to make sure that you find out exactly what the issues are. All right, compliance, we've got to mention this. Whether it's nursing, physician, anywhere, you've got to be aware of these compliance issues. You can't ask certain questions. So, you're like 60, when are you going to retire? You cannot do that. That's a civil rights violation. So, we've got a lot of, our partners are all Jewish, so we were hoping to find kind of a Christian partner so we can have some of these Jewish holidays covered. Or the other way around, you can't ask those questions. We're tired of working Christmas. You would have a leg up on the next candidate if you just convert over to Judaism. You can't do that, so be careful. And then the whole gender thing. If you get into the situation where you just can't figure things out, and it's begging the question, don't ask. You guys remember Pat, right? Okay, so I could see you asking the question, so do you have a significant other, Pat? Yes, so what's their name? I got them here. Chris? You just can't figure things out. Do not ask about these sort of things. You can get yourself into a lot of trouble, particularly if you don't hire them. All right, closing the deal. I think you should be prepared. You should absolutely be prepared to sign that person when you're interviewing them. You should have a contract in hand with their name on it. If it doesn't work out, well, don't pull the contract out. But if it's working out, go ahead and pull the contract out and say, what I heard on the phone and what I've seen today, I know you are the right person. I want you to be here. Because I'm so committed to that, I'm giving you a contract right now. You don't have to sign it now, but I want you to know we're seriously committed to having you here, review it, and get back to us, but you're offering them the job there. Why did you bring them in for an interview, fly them in most of the time or whatever, put them up in a hotel, take them out all day, a day of your life, a day of your work schedule gone for a maybe? Don't interview people you don't want to hire. Don't even bring them in if you're not really willing to hire them. And cue up the wants and the needs from the interview. Be positive. What do they need to make this work? So you're looking at other jobs, and we know right now, especially the good, there are a lot of open departments, a lot of open positions, and there are a lot of candidates out there, nursing-wise and physician-wise, but not enough for all of us. So you've got to ask them, what would make you want to be here as opposed to other jobs? And I'll make that happen for you. And then with the psychological contract, you make that happen, and you will engender trust between you and that person. So make sure you're ready to close the deal. What's amazed me with the whole recruiting process, I can't say as much for nurses, but for physicians, it's like a courting, dating ritual, like of the cockatoo. You dance around each other, and nobody wants to commit, and then I'll call you in 2 weeks. Please call me. And it's the whole. This is not dating. I don't know why we act that way. So we are interviewing other candidates. I'll be dating around a little bit. But you might be the one who I'll go out with next week. You know what happens to candidates that you don't commit to? They interview somewhere else, and when you get around to calling them, making them long for you, someone else committed to them and they're gone off the market. This isn't dating. And I don't really recommend that approach with dating either. If you found the right one, just go for it. Right there. Right there. You're at dinner and you're like, you're the one. Check, please. Let's get out of here. You've got to commit right there. All right, so close the deal. All right, recruitment blunders. Here are things that I've encountered as a medical director, as a regional director, and just stories I've heard from people in our specialty, and these things have all happened. If you have stories, you have thoughts on these, let me know. I think they're kind of funny. Not showing up for the interview. It's set up, somebody flies in, and oh, you're on vacation that day. You're gone. How really likely are you to sign that candidate at any point in time? They're not even going to come back for another interview. It's bad. Taking calls or checking your BlackBerry during the interview, oh, that is a bad thing. Hand it to someone, put it on vibrate, turn it off, whatever you need to do. All you're saying, and this is in your personal life too, whenever we're always checking, when we're engaged in doing something with somebody, all we're saying is, hold on a second, I'm about to show you how important I am and how little importance you have to me. Okay, you can be important again. It's just kind of a power move. Don't do that in an interview, because you're going to tell people, okay, all right, you're ready to hear me again? This is their day for you to say, everything's off my table. Everything's off my plate. This is about you. Working a shift on the day of the interview, that's not how you interview people. Well, I want you to see how the department works. Well, then the two of you can watch somebody work in the department. Not introducing candidates to the leadership. If you think somebody is special enough to be in your department, they need to meet the CEO of the hospital. If the CEO is not interested in meeting the emergency physicians that you're bringing in, then you need to think about being at another hospital. It's really a bad situation. What happens when the hospital hires a new vascular surgeon? Can you hear the music already? Dancing girls, roast beef, red carpet, the whole thing happens. It's amazing what happens. What happens when the new emergency physician shows up? Your mailbox is over there. It's the one with the tape over it from the last guy that was on there. I mean, the hospitals don't do anything. We have to, as medical directors and as leaders, say we're doing something special here. We deserve and command the same respect for our physicians as we do for others in the medical community. So make sure you force that commitment from your hospital. All right, stalling, that's that whole dating thing. You stall on whether you're going to commit to somebody. Bad plan. Interviewing candidates you don't intend to hire, that's a waste of time and money. It really is. Don't interview somebody that you don't intend to sign. And then the whole shopping thing. If you are looking for one person and you find somebody who will fit well on the first interview, sign them. If you think there was somebody great on paper that you want to interview, well, interview them too and hire them too. I mean, you can't hire 20 docs for a department that needs 5 docs. There are some limits. But if you find a good fit, I don't think you should be shopping too far because the other people may not be as good as you think. All right, offering special deals. This is so important. How many of you would like to do the same work for less compensation or for more shifts or different parameters than somebody else just because they were a better negotiator than you? Would that make you be frustrated? Would that damage your psychological contract with your employer? Absolutely. I think what we all need to do is find what we can do with our departments and say this is the most we can compensate. Let's get the best package possible and let our candidates know this is all I have. And when they ask you, well, I want a little something, I want a signing bonus like 20 grand. You know, I can't do that and this is why. Because she didn't get that and it's not fair to her and I can't go ahead and give that to her now, we can't afford it. So if we want this to be a true democratic department and take care of each other, we have to be equal. This is the most we can offer in our package. I'm sorry if it doesn't work, but we've stretched it to the max. Don't put flexible ranges in there so you can say, oh, for this one, I'll go a little higher. Maybe that person may have more value to you for some reason, but the other person's going to leave when they find out. When the other person feels like they provided the same service, and they find out, and they will find out that a special deal was cut, they're going to leave. And then the others are going to say, wow, I wonder what my deal is like compared to that deal. Don't do it. No special deals. Trying to recruit after you quit? Sounds kind of silly, but you know, if you've put in your notice as a leader in your department, trust me, recruitment is done for that year. And this may help you too, you know, with negotiation with your employer. If you're in the recruiting season, they do not want you to leave, even if they might want you to leave after, because recruitment is done until you get a new director in there. All right, not including the spouse or significant other, very important. Oftentimes that's who you're selling on the community or to make sure that they're comfortable in the community. The doc or the nurse is working super busy in the department. Are they really going to be as involved in the community? Maybe not, but the other family members are. Not including a social function. You've got to do something socially with these people so you know you can interact with them and they know that they can interact with you. You can kind of bond with them. And you've got to include others from the group. If they don't know who their partners are going to be, their coworkers are going to be, it's hard to establish a fit. And don't double book. This is a great story. This happened about 1.5 years ago. Okay, here's the stage, all right? Candidate is ready for their interview dinner. They're starting for whatever reason. They came in that afternoon. They're meeting the medical director for dinner at a special restaurant. Very nice place. So the spouse is here, and the candidate is here, and they're like waiting. They're checking their watches. It's like a half an hour later, and the medical director's still not there. And then, you know, they're sitting next to this other couple. There's other 2 or 3 or 4 people at this table. And finally, the couple who flew in are kind of bickering at this point, and the wife says, okay, do me a favor. He says, what? What? You know, you've been there. What? At this point, everything's what? Because everybody's mad. So do me a favor. Call the medical director. Why? He's not here. Just do me a favor and call the medical director. Punches the number in, and the phone at the next table's ringing. So they double booked. He was at the next table having dinner with another candidate and his spouse. What happened to those two who were waiting for 30 minutes? Got up, walked out, never to be seen again. Rookie mistake. What a horrible thing to do to somebody. All right, retention. How important is retention? It's probably more important than recruitment. If you find the people that you like and you want to work with, It takes less effort to maintain them there than it does to find somebody new. And the somebody new that you may find may not be as good as the person you wanted to keep. So retention is recruitment spelled differently, a little different skill set, but very important. The importance is huge. Make sure that we maintain the right staff and don't lose critical pieces. Strategies. You got to walk the walk. It is easy for all of us to talk and make sure that we're saying the right things. But if you walk the walk in your department and let those people know that this is where we're headed, and you're a great medical director as opposed to a good one. Good medical directors do this, and good nurse managers do this. They put out flash fires. Every day there are flash fires. We put them out, we stomp them out, and we make sure that nothing bad happens. That's okay. But a great leader will put out the flash fires while they're maintaining their vision and mission for a long-term change in the department. You want to be able to look back and 5 years later say, this is a different department than when I started. It's in a better place than it was. Not I put out 10 flash fires and the place didn't burn down. It's the same department, but nothing bad happened to it. You've got to put out the flash fires and move forward. And so you want to be a great director. So if you're walking the walk and letting people know you're maintaining the vision, that's the way to go. Cultivate relationships. You've got to bond with your people or they're not going to stay. Address concerns and needs with the physician and their family. How can we make it better for you? How can we make it a comfortable place for you to stay? And be creative. Do anything you need to make it work for them. You know, everybody has special needs that if it would, not like they're wearing helmets, not that kind of special needs, but the kind of special needs that, you know, my life would be a little easier if I just had this one little thing. And if you can make that one little thing happen, again, they're going to appreciate it, and they're also not going to be prompted to leave. Get a commitment up front is important. When you're signing somebody, make sure that you ask them, hey, you know, I'm expecting this is a long-term fit. So I'm expecting you would be here, you know, probably at least 3 to 5 years. Are you willing to commit to that? Believe me, that conversation carries power and value. Because if things start to get a little dicey, you'll say, you know, we talked about this. You said you were going to stay a minimum of 3 years. I need you to stay an extra 6 months to make your 2 years then. Okay, fine. You know, that conversation is crucial. Opportunities for professional growth, it's important. Provide people a chance to develop professionally so they can be better tomorrow than they were today, and you've had a part to do with that. Opportunities for financial growth, don't let them be stagnant. So if there are roles for them, EMS director, quality director, whatever it is, and the ability to flex up by incentivizing good behaviors. Maybe it's productivity, maybe it's patient satisfaction, whatever it is. If you work harder, you're going to get paid more. Cover the night shifts. How many of you love to work night shifts? I'm sorry, I didn't see the hands. Oh, yeah. Okay, well, you're hired. You are absolutely hired. I have the contract right here. I'm not gonna do the dance, nothing else. You're hired. No, seriously, covering the night shifts is helpful. I think the majority of us don't like to work nights. Some docs like to work nights because they know it's a value, there's extra income for it, and they'll do it short term, a few years. But most of us don't want a career of nights. Now, my strategy is really pay a lot for nights. Do you have to hire a nights person? Do you have to find that one person to work a bunch of nights? I don't know if that's healthy for them either. How do you know when you're paying enough for night shifts? Anybody? Nursing or physician-wise, doesn't matter. How do you know when you're paying enough for them? Well, you're fully staffed, and when people are pissed off, they're not getting enough of them. You know what? Sally got 5 night shifts. I only got 4. Oh, this is a wonderful world, isn't it? And you can find that magic number. And I tell you, I bet your partners, and maybe even the hospital on the nursing side would agree, whatever money is necessary to get you there and to keep everybody happy and to get the night shifts covered is probably worth it. And have them equitably distributed as opposed to having 1 or 2 people try and work them all. And I think it's helpful. You have to add an extra $20 an hour, $30 an hour, whatever it is. I think it's worthwhile because they're ugly shifts to work. All right, payroll has got to be on time. If you want to be a good director or a great director, I tell you what, nurse manager or physician leader, you've got to get payroll right and on time, and the schedules have to be out on time. If you can do those 2 things, people will stay fairly reasonably calm. But if you can't get a schedule out or they can't get any of their requests or their pay doesn't come in, oh, people are freaking out when that happens. Frequent performance reviews. People like to know how they're doing. It's not necessarily all positive. You can give some constructive, negative feedback. Hey, this is one thing I think you could do a little bit better. You're doing great with X, Y, and Z. But with this, I'd like to see you move forward a little bit this way and improve. And we'll talk about it next month or next quarter. Solidify each doc as a crucial member of the team. Everybody brings something to the table. Let them know what that is. I'm glad you're here because you're the person that does ultrasound. Or you're the person that we lean to for reviewing the literature. Or you know what, you're the fastest doc. Or you have the best satisfaction. You've got to let everybody know you have a piece here that no one else has. Construct a great working environment as best you can. And above all, get them to buy a freaking house. Once you buy a house, you guys probably been in the situation. Once you've bought the house, you've bought the community, oh, and you have bought the job. You really have. It's kind of painful. So, I mean, on the other side of things, I'd be a little cautious when you're looking for those jobs. Sometimes you want to rent, lease, or whatever. And I've been down that road before, but once you buy the house, you're fairly well committed. And I've heard medical directors say that, you bought a house, I'm golden. You know, when you get that real estate agent out there, but that should be a secondary visit. The first visit should really be just looking at the community. What's that?
They bought the house, they won't pay the bonus.
Yeah, there you go, there you go. All right, unfair scheduling. As far as retention blunders, that is a bad thing to do. You know, we have equitable scheduling except for you. I mean, it's not fair. And you burn somebody on the schedule a few times, guaranteed they're pulling the contract out. They're already looking at other opportunities. Taking your eye off the ball. We need to know all of our people. And if we're a little bit sensitive to their needs, we can say, you know what, so-and-so's been pretty quiet lately. Or I used to get phone calls on a weekly basis about this or that, and their input was valuable. Now I'm not hearing from them. You've got to manage those relationships. Again, no special deals for special people. We're all special. Accepting poor performance. You cannot tolerate poor performance. And this is all over the business literature also. This is a well-known phenomenon. If someone is not performing well in a department, and everyone else sees it, and they know it's tolerated, where's the benchmark set at that point? It was here. You've now tolerated this for 6 months, whether it's core measures, whether it's showing up for work on time, no matter what it is. Now the benchmark is here based on your inaction. You cannot tolerate poor performance no matter how understaffed you are. Otherwise, you're going to undermine the whole quality of your department. Not fulfilling promises. If you told somebody you were going to do something, you need to figure out a way to accomplish it. And don't make promises that you can't fulfill. You've absolutely got to be credible with those promises. Asking others to do things you haven't done yourself, you've always got to make sure that, listen, I need you to pick up an extra weekend shift this month because somebody got sick. And I've already picked up 2. So can you pick up an extra one? Don't say, listen, you know I haven't worked a clinical shift in 6 years, so I'm not going to pick one up. But I want you to pick up 4 because that would make everybody's life easier. You can't do that. Lead by example. Top-down management is bad. Get people's input and their buy-in. You know, they're professionals, whether on the nursing side or the physician side, their input needs to be at least heard. And if you don't, and you just say, listen, this is just the way we're going to do it, well, but I thought, no, I told you. I'm the smartest one here. That's why they made me the director. So you can just listen to what I say and you'll be fine. Trust me. But I thought, nope, that was your first mistake, was thinking. I'm the thinker. You're the doer. Thinker, doer, thinker, doer. You can't do that to people. No top-down management. Failure to identify viral dysfunction. This is huge. Have you ever seen a department where somebody doesn't like what's happening and they go to the next person, whatever it is? I hate this whole patient satisfaction thing, and I don't know why the hospital's looking at this, and we don't need to please these people, and then they go to the next person, or maybe it's the chronic pain patient. You know what? We're going to get a pain file, and we're going to put the whole visit log on the front of the chart before the doc even sees the triage note. That way, when Mary comes in with her migraine again, they'll know, and they'll just send her home and tell her never to come back. You know, if you see that kind of viral dysfunction that's going from one person to the next, you need to get right in the middle of it. Nail it with some freaking Tamiflu right now, because it will ruin your department. You need to get to the source of it and stop it, because it will damage things for sure. All right, managing everyone the same way. Everyone is different, different personality types. This is what makes good leaders great leaders also, because you've got to manage personalities and manage people. Really, this is why we have nurse managers and medical directors, because we're managing professionals and we're managing adult behavior, and that is really challenging to do. And managing through friendship, this is a challenge. You want everybody to like you. If that's your goal, it's time to step down from your directorship or your nurse manager position. It's great if people like you. That cannot be your goal. It's great if it happens, but that can't be in front of the mission. The mission has to come first, and if some people don't like what happens with part of the mission, sometimes they're not going to be happy with you. But if you can look yourself in the mirror and feel good about what you're doing for the patients, for your department, for the community, for the hospital, you're doing the right thing as long as you're being respectful to other people. But don't try and manage to gain friends. You will not be a good leader. You will not be respected, guaranteed. All right, any questions?